Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your top free on-the-go source for radiology board review. This episode continues our discussion of nuclear cardiology. This is a multi-part series covering nuclear imaging of the heart. And after all of these episodes have been posted, I will make a free study guide on this topic available on my website, theradiologyreview.com. Other free downloadable study guides on other podcast episode topics are also available there for download. As a quick reminder, please follow at RadRevPodcast on Twitter and Instagram, where I am currently posting near-daily tips covering radiology physics. Without further ado, let's get into the questions and answers for this episode. First question: by which mechanism does thallium enter into a cell? I believe I covered this on one of the first podcast episodes I released, so long-time listeners, let's test your memory recall of this question. The answer is that thallium enters a cell using a sodium-potassium pump in a manner that is related to blood flow. The key here is that thallium is able to hitch a ride along the sodium-potassium pump to enter into the cell. Note that the sodium-potassium pump uses active transport. If the sodium-potassium pump is able to actively transport thallium into the cell, that is a sign that that cell is at least minimally viable and not dead. Let's go on to a related question. What happens after thallium enters into a cell? Importantly, unlike technetium sestamibi or technetium tetrophosmin, thallium is able to redistribute among cells in the myocardium. It is important to remember that on initial thallium imaging, because thallium does reach the cell in a manner related to blood flow, initial thallium imaging provides information about blood flow to the myocardium, and delayed imaging evaluates for redistribution among viable myocardial cells. And that also leads us to a related question. How does thallium distinguish between normally perfused, ischemic, and dead myocardium? And when I say dead myocardium, I mean infarcted or scarred myocardium. Thallium can show areas of ischemic but viable myocardium. Ischemia on a thallium scan will present as a perfusion defect on initial imaging, with uptake on delayed imaging within the area of perfusion defect, as thallium has time to redistribute into the viable but hibernating myocardium. So one more time, for ischemia, expect a perfusion defect on initial imaging that subsequently fills in on delayed imaging due to thallium redistribution, and that tells you that that portion of the myocardium is ischemic but viable. Next, for a scar or prior infarct on thallium, you would expect to see a perfusion defect on initial imaging that persists on delayed imaging. Remember that redistribution requires functional sodium-potassium pumps, and those sodium-potassium pumps will not be functioning in case of myocardial scarring. So one more time, with a scar, the perfusion defect on initial imaging also persists on delayed imaging. Finally, normal perfusion with thallium will manifest as no defect on initial imaging. And you are unlikely to see delayed imaging in this setting because if the initial imaging is normal, you have excluded either hibernating or scarred myocardium, and there really is no purpose for delayed imaging. Let's move on to the next question. On a myocardial perfusion study with technetium sestamibi or technetium tetrophosmin, how does imaging distinguish between a scar and ischemia? The key to differentiate between scar and ischemia on a myocardial perfusion study using either technetium sestimib or technetium tetrophosphate is to compare uptake between the stress and rest portions of the exam. A fixed defect on both stress and rest is consistent with scar from prior infarction. A reversible defect, meaning a defect that is seen on stress imaging only, with no defect on rest imaging, is a manifestation of stress-induced ischemia. Sometimes a fixed defect is seen with reversible components around the fixed defect. In other words, the defect is distinctly larger on stress images and distinctly a little bit smaller on rest images, and this suggests a component of scar with peri-infarct ischemia. That is very important to remember that if you have a fixed defect, but that fixed defect looks slightly larger on the stress imaging, what you are likely seeing is a scar with surrounding peri-infarct ischemia. Let's move on. True or false? A thallium lung-to-heart ratio study with decreased lung uptake suggests multivessel coronary disease. The answer here is false. Multivessel coronary artery disease would be expected to show some degree of myocardial dysfunction and increased uptake in the lungs as a result of reduced blood flow through the lungs, due to the cardiac disease not being sufficient to clear the tracer from the lungs. Let's move on. What are imaging manifestations and clinical implications of transient ischemic dilation? This is also sometimes termed TID. Transient ischemic dilation, or TID, is identified on a myocardial perfusion scan when the left ventricular cavity appears larger on stress imaging compared to rest imaging. Let's explain this further. First, remember that perfusion can appear otherwise normal in the setting of transient ischemic dilatation. You do not expect to see a focal myocardial perfusion defect. Rather, the left ventricular cavity simply appears larger on stress imaging compared to rest imaging. The finding of interest is simply that apparent left ventricular enlargement on stress imaging that is not seen on rest imaging. The significance of this finding is that this correlates with left main and/or three-vessel coronary artery disease that causes diffuse subendocardial hypoperfusion. This diffuse subendocardial hypoperfusion means that less radiotracer is delivered to the subendocardial myocardium. Therefore, this causes a diffuse subendocardial perfusion defect on stress imaging, and this causes the appearance of left ventricular enlargement on stress imaging. What you are actually seeing is the subendocardial perfusion defect that makes that left ventricular cavity appear larger, and this is a manifestation of a reversible subendocardial ischemic defect that is shown to correlate with left main and/or three-vessel coronary artery disease. So important finding to be aware of. So remember, transient ischemic dilation. If you need to look up an image of this, please do. Next, how might dilated cardiomyopathy manifest on a myocardial perfusion scan? In comparison to transient ischemic dilation, dilated cardiomyopathy would be expected to present with left ventricular dilation that is fixed on both stress and rest images. Next question. What is the significance of seeing increased right ventricular activity on rest imaging? First of all, let's define a little bit what increased right ventricular activity is on rest imaging. And I think you could simply think about this as right ventricular uptake that appears similar to left ventricular uptake. If the right ventricle shows higher than normal uptake on rest imaging, which would again manifest as something like the right ventricular uptake appearing similar to left ventricular uptake, This is a sign of right ventricular hypertrophy, and that is the answer to this question. Right ventricular hypertrophy can cause the right ventricular activity to appear similar to the left ventricular activity. Normally, the right ventricle shows uptake that is markedly lower than the left ventricle. Next, what is the difference between stunned and hibernating myocardium? Stunned myocardium is seen in the acute phase following ischemia, when that ischemia resolves, resulting in a reperfusion injury but not frank myocardial infarction or scarring. With stunned myocardium, this manifests on nuclear imaging as normal perfusion with impaired contractility of the heart. Remember, with a myocardial perfusion scan, you can obtain dynamic sequences with gating that allows you to see the heart actually beating and assess contractility. So with stunned myocardium, when the heart has been stunned from ischemia with some degree of reperfusion injury but not frank myocardial infarction, you would expect normal perfusion with impaired contractility. As the name stunned myocardium suggests, this stunning is temporary and typically resolves within a few weeks. Hibernating myocardium results from chronic decreased perfusion to the heart from chronic severe coronary artery disease. Hibernating myocardium manifests on imaging as areas of decreased perfusion and decreased contractility in myocardium that is not infarcted and is still viable. A key to remember for board exams is that hibernating myocardium is viable heart tissue that is chronically hypoperfused and therefore poorly contractile, but if the perfusion is improved through some sort of intervention, such as stenting or angioplasty, cardiac contractility can recover to normal or else be significantly improved. Next question. How can one assess for viability of cardiac tissue using FDG PET-CT and/or thallium? Another way one could phrase the same question is as follows. How can one differentiate between infarcted myocardium and viable myocardium using FDG PET-CT and/or thallium imaging? With FDG PET-CT, hibernating myocardium is chronically hypoperfused and therefore very hungry for nutrients such as glucose. Therefore, FDG uptake will be more intense in hibernating myocardium compared to normal myocardium. And that's exactly how I remember this, that chronic hyperperfusion has delivered insufficient nutrients to the cell, and those cells are viable and hungry, so when FDG is injected, those hibernating cells will take up more of that FDG as a glucose analog compared to the normal myocardium. Now I should clarify one thing here. With hibernating myocardium on FDG PET-CT, simply showing activity in the area of decreased perfusion is sufficient to prove viability, and sometimes the area of hibernating myocardium will not show increased activity compared to normal myocardium, but will simply show activity in the region of myocardium that may be equal or even potentially slightly lower than normal myocardium. The key to confirm viability is simply that there is uptake in the region of the decreased perfusion, proving that there is viable myocardium in that region. With thallium imaging, the key for viable myocardium again is that thallium will redistribute into viable myocardium, but not scarred myocardium. In hibernating myocardium, on initial imaging with thallium, one will see a perfusion defect related to the chronic hypoperfusion, but again, on delayed imaging, thallium will use those functional sodium-potassium pumps to redistribute into any myocardium that is viable, but will not be able to redistribute into any myocardium that is scarred, because scarred myocardium will not have functional sodium-potassium pumps. Hopefully that is clear after listening to the several questions on this same topic. I want to close this episode with a quick summary of imaging for some of the findings we have discussed. Hibernating myocardium. With hibernating myocardium, a myocardial perfusion scan will show decreased perfusion and decreased contractility. An FDG PET-CT scan will show uptake higher than normal for myocardium, or uptake that is equal to slightly lower than normal myocardium. But the key is that there is FDG uptake in that region of ischemia. That shows you there are viable cells present, and thallium will show redistribution on delayed imaging. Hibernating myocardium is chronically hypoperfused myocardium that is still viable. Stunned myocardium. With stunned myocardium, myocardial perfusion imaging will show normal perfusion but decreased contractility. Remember that stunned myocardium is temporary and is the result of a recent transient ischemic insult to the heart. Ischemic myocardium. With myocardial ischemia, a myocardial perfusion scan will show less tracer uptake on stress compared to rest imaging, and this is termed a reversible defect. With ischemic myocardium, you expect poor contractility in the ischemic segments on stress imaging. Finally, for scarred or infarcted myocardium, in this setting, you expect no tracer uptake on stress or rest images in the infarcted, scarred myocardium, and no contractility in the infarcted segments, as the myocardium is simply dead in that region. On thallium imaging, you will see no redistribution, and with FDG PET-CT imaging, you will see no uptake. That concludes this episode. I will continue our discussion of nuclear cardiology on the next episode, and we'll cover other types of exams to include MUGA, sarcoid imaging, amyloid imaging, and so forth. I hope these episodes are helpful for many of you. As a reminder, after I have posted all of these episodes on nuclear cardiology, I will make a free downloadable study guide available on my website, theradiologyreview.com, where you can find this and other free resources for radiology board exam preparation. Thank you for listening to this episode. Keep up the good work. Study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.